Welcome, everyone. I can see our numbers ticking up. We're just at the top of the hour, and I'm going to let a few folks start to continue to join the session as we get started. So thank you, everyone, for joining us today. We're super excited about this topic, and it is a very important topic for a lot of our Action Community participants and as well as the field. We get a lot of questions about this topic, and that's why we've decided to highlight this for today. So for today, we're going to be talking about the age-friendly hospital measure, and we're going to help you prepare for a successful attestation. So I'm Rahat Ansari, Senior Program Manager with the American Hospital Association, and have been leading the age-friendly work for almost 10 years now. And with that, we can go to the next slide, and I'll run over how we're going to spend the next hour together. So today we're joined by our policy expert, who I'll introduce formally in just a moment, and she'll take some time to go over the background of the importance of this measure's development, the history, and really going over the why about this measure. She'll take some time to go over the specifications. She'll take some time to talk about the CMS attestation guidance by domain, which really gets at the how. We will share some age-friendly health systems resources that are always beneficial and have some pretty good comments from the participants that receive them. We are also joined by Dr. Mwangi, and she is from Luminis Health, and she's going to share her journey on her experience with this measure. We do have time for questions at the end of this session. So at the end of this hour-long session, we will have time and open it up for Q&A. You are welcome to chat in your questions along the way. So you should all see a chat. Either it's already populated to the side of your screen, or you can click on the chat function at the bottom of your screen, and you can continuously chat in your questions and comments as we're going through the presentation. Or you can use your Q&A functionality, which if you click on the ellipses at the bottom of your screen, you'll be able to access that functionality. So you're welcome to chat in your questions either way. And so with that, we'll get to the meat of the content. And I'd like to introduce Catilin Gillooley formally, who is the Director of Behavioral Health and Quality Policy at the American Hospital Association. In addition to developing policy positions on quality measurement, quality improvement programs, and value-based purchasing models, Ms. Gillooley leads the AHA's work psychiatric substance abuse disorder treatment policy, as well as maternal and child health, post-acute care, and outpatient ambulatory settings. Her role includes analysis of the operational and clinical implications of regulations and legislation, including the effects of these laws on care outcomes for individuals with serious mental illness, substance use disorders, and other behavioral health issues. And as I mentioned, for the second half of this presentation, we will be joined by Dr. Mwangi, who is a geriatric hospitalist and medical director of the Acute Care for the Elderly Unit at the Luminis Health and Arundel Medical Center in Annapolis, Maryland. She is board certified in internal medicine and geriatrics, and her clinical focus is care of hospitalized older adults with a special interest in the implementation of age-friendly care principles. She also has a strong background in hospice and palliative care medicine, having served as an inpatient physician supervisor for palliative care advanced practice providers. So with that, Catilin, I will turn it over to you.
Great, thanks so much. So I'm Catilin Gillooley. So I lead our work on quality policy at AHA. So as Rod mentioned, this was our work on all of the quality reporting programs and everything else that comes out of CMS, which is the Center for Medicare and Medicaid Services. So I'm going to be using that acronym quite a few times. If I inadvertently use an acronym that you're not familiar with, please just let us know. And I can walk through what that means. So let's go ahead to the next slide. And I want to start off giving some context, some background on the measure, which I think is going to be helpful in interpreting CMS's rationale for implementing this measure into the program, really what they're trying to get out of it. And I think that that context is important because it connects the measure with the work that you are likely already doing for the most part. And then, as Rahab mentioned, I'm going to walk through the technical aspects of the measures and then really talk about what it is from CMS's point of view that they are evaluating and how you can say yes to these various items of the measure. So starting with the rationale, under CMS's national quality strategy, the agency seeks to improve the quality of care through its various programs, and it's organizing its programs the way that you see on the right side of your slide. There are 4 areas and 8 related goals, and this measure that we're talking about today fits under the goal of equity and engagement. CMS looks for ways to advance whole person care and engage individuals and communities to become partners in their care under this goal. And then specifically, CMS is trying to achieve that goal by improving quality in high priority clinical areas, which in this case would be care for older adults. And I'll start by mentioning that you will get the PowerPoint afterwards, and there are going to be some helpful links in there as well that I will reference. So the measure, a little bit of background on this measure, a history on it. The measure was originally presented for consideration by CMS and by other stakeholders as 2 separate measures. One on surgical best practices for older adults and one on just general hospital care for older adults. But stakeholders and CMS and the measure developer agreed that there's a significant overlap between the 2 measures, and we also need to look at a desire. We wanted a holistic and hospital-wide focus on the approach to care for older adults, and there's no need to kind of pigeonhole it into surgery for one set of standards and general hospital care for another. So this structural measure spans the breadth of clinical care in the entire pathway, and it provides a broad framework for optimal care for the older patient. Now, there are existing quality metrics that are focused on outcomes of importance to older adults. So those are things like falls, readmissions, mortality. There are also measures that focus on process of care. So the appropriate use of anticoagulants and antipsychotics, for example, or there's also safety measures like severe hyperglycemia, hypoglycemia, pressure injury. We have all of those measures in the quality reporting programs already. However, these measures, according to CMS, can be narrow in scope. They might not be relevant to all older patients depending on their needs. You might not be susceptible to a pressure injury based on what it is that you're in the hospital for. So they may have limited wide effectiveness throughout the population. They also might have limited long-term effectiveness as we get better and better at providing safe care. Some of those measures may no longer be relevant, and they might be topped out as we say everyone's doing well on them and there's no room for improvement. So instead, the structural measure that we're talking about seeks to ensure that the hospitals are reliably implementing those 4 M's, what matters, mentation, mobility, and medication. And they're optimizing care, again, in a holistic approach rather than focusing solely on individual clinical issues. So in other words, the measure is looking to determine whether hospitals are implementing standards that, based on research, are associated with those improved patient outcomes that actually are individual measures. Now, in the proposal and the background development for this measure, the steward explicitly calls out the alignment of the elements in the measure with the Hartford Foundation's national initiative for age-friendly health systems. With the work that AHA has been doing, they cite this work, and they note that many hospitals already participate in these initiatives. And so just by being here, you're already in really good shape. So I'm going to editorialize just a little bit on why CMS is using this measure. And the purpose is not a gotcha. The agency is not trying to penalize or pick on organizations that aren't doing exactly what it says to do. And in fact, when they tested this measure, meaning, if we put this measure into a program today, how would performance look? It demonstrated that the average hospital is already doing most or all of the activities that are detailed in the measure. So we're already doing pretty well on this. The activities and the capabilities that are listed are done at a very high level rather than a prescriptive level. And it allows for significant flexibility for hospitals and health systems to provide age-friendly care in ways that are going to work best for your specific patient populations and your institutions. And you'll hear me come back to that quite a few times. So rather, CMS is using this measure to shine a spotlight on care for older adults, to keep these topics at the forefront, to demonstrate that age-friendly care is a priority in CMS's measurement programs. The agency argues that The structural measure is a way to address the topic of age-friendly care in a way that no other outcome measure can do. There's no single measure that says, yes, this older adult received optimal care. They also argue that by having this as a required measure in the Inpatient Quality Reporting Program, or IQR, it sets the expectation that hospitals will continue to develop evidence-based programs and processes that support improvements in high-impact populations like older adults, rather than just looking at disease or procedure-specific outcomes. And then finally, CMS kind of indicates in their proposals for the measures and various rulemaking that it's a jumping-off point. This may inform, inspire, or be linked to outcomes measures to be developed in the future. It may change based on what best practices are developed. So this is kind of a starting point for where we are. So on the next slide, you can see that we have all of the links that I accessed to inform this measure. So I've been working on this measure and viewing it for quite a while, since it was first introduced to the quality measurement landscape several years ago. But everything in this webinar is based on the resources that are linked here. And the webinar is being recorded, and we will distribute the slides afterwards, so you can access all of these links. None of this is my opinion or my interpretation. This is all directly from what CMS has put out there for use. I just kind of put it in an order that I think is kind of easier to digest. But it is important that hospitals and health systems familiarize themselves with measure specifications to ensure that they are accurately reporting the data. So let's talk about the measure, starting on the next slide. You know the why behind CMS's use of the measure. Let's talk about the what. Again, we're setting the stage so that we're all on the same page before we dive deeper. I understand some of you might not have any exposure to this measure yet, and some might be very familiar. So CMS added the age-friendly hospital structural measure to the IQR, again, that's the Inpatient Quality Reporting Program, beginning with the calendar year 2025 reporting period. And I'll talk about what that means in another slide. It joins two other structural measures in the program, the Patient Safety Structural Measure and the Maternal Morbidity Structural Measure, which is also known as the Birthing Friendly designation. The measure consists of 5 categories of policies and practices that are associated with achieving better outcomes for older adults. Now, across these 5 categories or domains, there are 10 statements to which hospitals are asked to attest. So in other words, respondents will be faced with several statements of my hospital does X, and they will be asked to say, yes, my hospital does do that, or no, my hospital does not do that. So let's talk about what the details of reporting this measure entail on the next slide. So since this measure is part of the IQR, all acute care hospitals that are paid under the Inpatient Prospective Payment System, or IPPS, or subsection D hospitals, are required to submit data for it and all the other measures in the IQR. That means that this does not include inpatient psychiatric facilities, long-term care hospitals, inpatient rehabilitation hospitals, children's hospitals, and the 11 prospective payment system exempt cancer hospitals. Reporting for this measure involves a once yearly submission of a form on the HQR website. There are a lot of inpatient measures, including the other structural measure, the Patient Safety Structural Measure, which are reported via the National Healthcare Safety Network, or NHSN. But this measure we're talking about today lives in the same place as all of the other data exchange functions between providers and CMS. So saying yes or testing positively means that, to the best of your knowledge, your hospital undertakes certain activities or has established certain policies and protocols for the majority of patients age 65 and older. So 51%. The reason we say that 51% or the majority means that if you have a handful of patients that did not receive a certain kind of screening, but it is a matter of course in your organization, or it's a standard practice that your facility does perform those screenings on all other patients, you can still attest yes. So you don't have to go through and say every single patient received this screening. As long as the majority did, as long as more than half did, then you are good to say yes. This also applies for patients hospital-wide, meaning that whether they're admitted to the inpatient hospital, in the emergency department, or receiving procedures in the operating room. So to answer a couple of questions in the chat really quickly, critical access hospitals are not required to participate in the inpatient quality reporting program. They are encouraged to do so. The Puerto Rico hospitals, if you are paid under the inpatient prospective payment system, you are also required to do it. So it has nothing to do with the geography. It's really where you're paid and the requirements under that payment system. So respondents can determine whether they undertake the activities that are mentioned in this measure or have established these protocols by looking at their administrative data, their claims data, their EHR capabilities, their social needs assessments, their clinical registries, their paper medical records. But the important thing is that none of that information, none of those documents need to be submitted to CMS for this measure. You can just find out whether you're doing these things by referencing those and other sources of information. Now, the first reporting period for this measure is 2025. So that means that you are going to be asked whether your hospital did all of these things in the year 2025. The first submission period is from April 1st through May 18th, 2026. That means that you're going to fill out the form about what you did in 2025 in that month and a half time frame. The form will become available on April 1st, and that form submission period will close on the 18th. Whether or not you successfully submitted that form, as well as other IQR measure data, will impact your annual payment update in 2027. So in other words, if you didn't complete the data submission for this or any other other IQR measures in the reporting period, then your payment is going to be affected then. So those are just kind of the, when I say respondents, I mean the people who are answering the form, who are filling out the form. And it's generally the, quality office, and so anyone else who is responsible for data submission for quality measures. And I say respondents because that could be the same person who's doing the HAI measures and all the other ones, or it could be someone who is on the age-friendly team who is answering this on behalf of the quality reporting office. But at the end of the day, it's the folks who have the HQR login that are submitting the data that are going to be submitting that form, but you can have other people help you fill it out. All right, so let's talk about what performance on this measure looks like on the next slide before we get into some of the details. And these, I think, are really important things that are good to know. So the web-based form is simply yes or no answer. These are all attestations. There is no supporting documentation or details that are necessary. So the question will say, did you screen patients for frailty using a validated tool? And I'll get into specifics later. Yes or no. So you just say yes or no. You don't have to list the tools you used. You don't have to describe your process. You don't have to provide any sort of evidence of proof. You don't have to put in a sampling of claims or any of that. So that's the entirety of the measure. It's 5 domains. Each hospital will receive a score out of 5, meaning how many out of those 5 categories or domains you were able to attest positively for. Now, there is no partial credit. Some of these domains or categories have multiple attestation statements under them. So they have multiple questions. And you have to attest positively to all of those questions to get a credit for it, to get a point out of 5. So for example, domain 3 has 4 sub-items. Does your hospital do A, B, C, and D? If you say, yes, we do A, B, and C, but we don't do D, then you don't get a point for that domain. Now, CMS does not expect every hospital to get 5 out of 5 in the first year. That's kind of the point of quality measurement. That would be like a measure asking, does your hospital have doors? Of course, why ask about it if we already know the answer? And so that's a really important point that goes along with the next one, that this and all other measures in the inpatient quality reporting program is pay for reporting as opposed to pay for performance. That means to meet the requirements, you just have to report the data. You don't have to achieve all 5 domains. You will still get the full payment update, even if you say, no, we don't do any of this, as long as you tell them on the form by the deadline that we don't do this. You have met your requirements. This measure does not require the implementation of any of these items that are listed. In other words, if you say, no, our hospital doesn't do this screening, you will not be penalized by CMS. There are ways that CMS ensures accuracy of this measure. There is no data validation mechanism for this measure. So, for example, for other measures, CMS undertakes a process where they collect a random sample of hospital submitted data and they check it for accuracy against other data sources like claims. But as I mentioned before, there is no single measure or single data source that contains all of the information about providing holistic, optimized care for the older adult in a standard format that CMS could use for that purpose. Now, obviously, that doesn't mean that accuracy isn't important and factuality isn't important. And that's because every year a hospital is required to submit a data accuracy and completeness agreement, or DACA, which says essentially, I'm not lying when I submit this data. And generally, it's the hospital CEO who is the authorized representative providing the signature. So it's your hospital CEO who is held to that standard. Hospitals that don't meet the IQR requirements, which includes the signing of that form and the submission to the best of the signatory's knowledge of accurate data, they are penalized with a reduction in their annual Medicare reimbursement update. So let's say that you answer untruthfully on this survey or on this measure, and then CMS finds via survey or in the investigation of a patient complaint that there actually are inconsistencies between your policies and procedures and what you've attested to, that you could be penalized. So you say we do the screening for all patients, and then you receive several complaints that no, we did not receive this screening, and CMS goes in and follows up and discovers actually they have no process for this screening, then you could be penalized for that. But in terms of the content of the measure, that's not what we're looking for. They're just looking for the yes or no. And then the last item is that this information, the performance on this data, your score out of 5, will be publicly reported on Hospital Care Compare. The agency intends to provide educational materials as part of their outreach and public reporting of the measure to kind of help understanding and interpretation of publicly reported data. So, what does it mean that the hospital got a 3 out of 5? Those educational materials are not out yet. They will likely come out in the fall of 2026. And then the measure will likely be publicly reported in the fall of 2026 or the spring of 2027 with those refreshes. Excuse me. So now let's walk through each domain and we'll talk about how you can say yes. I'm going to explain what each domain and each attestation statement is looking for, and then we'll provide some kind of clear ways or obvious ways and examples of what a hospital can do to say, yes, we do what CMS is asking about. But again, these are not an exhaustive list. So let's start with the first domain. The first domain is eliciting patient healthcare goals. So this domain focuses on obtaining patients' health-related goals and treatment preferences, which will inform shared decision-making and goal-concordant care. You have to attest, excuse me, that your hospital is in place to ensure patient goals related to healthcare. Patient goals related to healthcare, so their health goals, their treatment goals, living wills, identification of healthcare priorities, healthcare proxies, advanced care planning are obtained and reviewed and documented in the medical record. The goals are updated before major procedures and upon significant changes in clinical status. So to translate, do you have a process by which you have conversations with patients about their goals? Do you write the goals down in the medical record somehow? Do you have the conversations more than once? CMS doesn't require any specific process, protocol, script, list of questions, tool, survey, or anything to have these conversations or process to document them. And that's because a lot of this depends on your patient, their situation, your organization, where they are in their care journey. Documenting in a medical record can be as simple as listing it out in an open field, sort of the same way you do for reason for visit. But many EHRs do have modules or built-in capabilities that can facilitate this, like keyword tags, or the longitudinal plan of care feature, or questionnaires sent via messaging. So if you're doing any of those things, you can say very confidently, yes, we can attest to this statement. CMS does recommend that you revisit these conversations with patients if there are big changes that might affect their goals. So a new diagnosis, a change in health status, a life stage change like retirement or enrollment in Medicare. A new episode like a hospitalization or admission to a skilled nursing facility, as well as over time. So maybe during their annual wellness visit. So I'll pause here so you can take a look at this slide, and we will distribute them afterwards. But we'll pause here just for a second.
And there are some good questions in the chat, and Caitlin is doing a great job responding to them in real time. And I'm also recording some of the answers in the event that somebody has the same question as returning back to, comes to mind at a later point in time. So continue to write in your questions, and again, we'll have some time to go over them at the very end.
Yes, excellent. So a lot of these questions are going to be answered as we go on to. So let's go on to domain 2, responsible medication management. So this domain aims to optimize medication management through monitoring of the pharmacological record for drugs that may be considered inappropriate for older adults specifically due to increased risk of harm. So the attestation statement says our hospital reviews medications for the purpose of identifying potentially inappropriate medications, PIMs, for older adults. Those are defined by standard evidence-based guidelines, criteria, or protocols. The review should be undertaken upon admission, before major procedures, and or upon significant changes in clinical status. Once identified, the PIM should be considered for discontinuation and or dose adjustment as indicated. So PIMs are already defined. These are things that are defined by best practice guidelines, and they specifically recommend that the prescribing practitioner should avoid medications that do things like induce delirium or other untoward events in older adults. These are generally classes like benzodiazepines, hydroxyzine, sedative hypnotics, meperidine, these things that you know are not are on your list for older adults to be wary of. An example that's cited is the AGS Beers criteria, and they use specific categories to list the PIMs, including medications to avoid outside of a hospice or palliative care setting, for persons with certain healthcare conditions, those that cause adverse drug interactions when combined with other medications, those with side effects outweighing their benefits, and those with adverse effects on kidney function. CMS also cites the stop-start criteria, has a lot of overlap with beers. But again, they are not requiring that you use AGS beers or that you use stop start. Those are just examples. Do you reference some evidence-based guidelines such as stop start or beers? So CMS is asking whether your hospital has processes built into the clinical workflow to identify whether an older adult patient specifically may be on a medication that could cause harm. So these are processes like standardized order sets, pharmacy review, EHR flags that pop up upon detection of, say, you have concurrent prescriptions of opioids and benzodiazepines or antipsychotics. They're also asking if you have ways to mitigate that risk for harm if the aforementioned processes do flag as a PIM. So things like, yes, if we see that a patient is on one of these medications, we take them off, or we phase it out, or we find an alternative, pharmacologic or not. So I'm going to walk through and answer a couple of questions in the chat in class. This is standard pharmacy work. My mom, who is a pharmacist, I asked her, and she, even before I said AGS beers, she said, "Oh, you like AGS beers." So this is standard pharmacy work for this. The medication is for medications that the patient is on. So if they come in and they're on a list of medications, are you reviewing the medications that patient is on? Both that they're already on and that you were going to dispense during their hospitalization. So it's really just their medications. And you should do that upon admission, so you can see as they come in, are there any things that we need to flag while they're here? Upon discharge, as they're leaving, is there anything that we are prescribing that may interact with something that they have to continue? So let's move on to domain 3, frailty screening and intervention. So this domain aims to screen patients for geriatric issues related to frailty, including cognitive impairment and delirium, physical function and mobility, and malnutrition for the purpose of early detection and intervention where appropriate. So unlike the first 2 domains that we've already walked through, this one has 4 individual attestation statements. And remember, in order to get a point for this domain, you need to be able to say yes to all 4 of them. The first one, our hospital screens patients for risks regarding mentation, mobility, and malnutrition using validated instruments, ideally upon admission, before major procedures, and or upon significant changes in clinical status. CMS lists several tools in its attestation guide, But they also acknowledge that those are just some of the available validated instruments that institutions may choose, and that there are certainly others. They also note that you can tailor existing instruments. You can use multiple screening tools to address separate risk factors. So, for example, you have the CAM for cognitive impairment, and then you can use a different tool or part of a different tool for physical impairment. They strongly recommend, but you are not required to use the same screening tool across touch points. So admission upon discharge just for internal consistency. But again, there's no requirement that you implement that. And then screening can be performed by any member of the care team. This is true for the medication review as well, that screening can be performed by any MD, APP, nurse, social worker. That's because these screenings, these are not diagnostic. They're just flags. So the assumption throughout this entire tool is that you are also providing clinically appropriate care. This part is just, are you paying attention to the issues that are important to older adults? And so and then they get to all of the appropriate clinical care in the other outcomes and process measures. The second attestation statement is our hospital utilizes positive screens, meaning we identified an area of risk, to create management plans, including but not limited to minimizing delirium risks, encouraging early mobility, and implementing nutrition plans where appropriate. The plan should be included in discharge instructions and communicated to post-discharge facilities. So, you've identified a risk and you're implementing some kind of management plan as soon as appropriate. So as soon as appropriate may mean, if this is an elective procedure and you know that they're going to be at risk for falls, did you ask about fall risks before they came in and say, we're going to have to make sure that your home, if that's where you're going post-discharge, is free of fall risks. If they are emergency or non-elective, you have a 48-hour post-operative window, or as soon as clinically appropriate, to put together a management plan. And when we say reducing risk, these are things like making sure patients can get their glasses or their hearing aids, writing a legible daily plan on their whiteboard in their room, doing medication management. So these are all things that are that may be kind of obvious. Our hospital collects data on the rate of falls, decubitus ulcers, and 30-day readmission for patients age 65 and over. These data are stratified by variables of interest such as sex, payer source, age, and other factors the provider determines valuable in identifying improvement strategies for all populations. Now, if you participate in the inpatient quality reporting program, you are already reporting and being assessed upon measures that do this, including PSI 8, which is in-hospital fall-associated fracture rate, PSI 3, pressure ulcer rate, and the hybrid hospital-wide all-cause readmission measure. Stratifying by variables just means that you're looking at your data performance in specific patient categories. So how is our fall rate for patients who are over 65? How is our pressure ulcer rate for patients who are over 65? And of those patients over 65, how is it for women over 65? And then finally, our hospital has protocols to reduce the risk of emergency department delirium by reducing length of emergency department stay, with the goal of transferring a targeted percentage of older patients out of the emergency department within 8 hours of arrival and or within 3 hours of the decision to admit. The timestamps here are not the point. The point is whether you have an overall goal in your organization of decreasing delirium in the high traffic area of the emergency department. Do you have protocols that you share with the people who work in your organization to prioritize the transfer of older patients out of the ED in a timely fashion? They say you should identify a goal percentage of older adults to be transferred with the aim of increasing that percentage over time. But there is no ideal percentage. That's just how we improve quality. We set a goal and then we try to beat it. They do list some potential mechanisms that you can see that I listed on this slide to improve flow through the ED. But again, CMS does not require the implementation of any of those mechanisms. So I know that this group is really detail oriented. This measure, as a structural measure, is not asking so much about what is the timestamp that you had on every single patient that you got them out of the ED, and was that 3 hours? There is no way for CMS to check that in this measure. They are asking, do you know that you're supposed to be trying to get older adults out of the ED as soon as possible? And is that part of your process? Let's go to the next slide. Patient vulnerability. Like domain 3, this domain focuses on screenings that are tailored to the older adult population, but it does have multiple sub-items as well. And this is about kind of social vulnerability, social frailty due to unique stressors for the older adult population. So this is where screening for health-related social needs might, in general, at your hospital, might not otherwise be picked up by the screening tools that are meant for that general population. So these are things like poor nutrition, low activity levels, isolation from the community, financial stress because they're on a fixed income, flags for elder abuse, neglect or exploitation. And so the attestation statements really boil down to, we screen older patients for age-related vulnerabilities, including isolation from community, economic insecurity, limited access to healthcare, caregiver stress, and elder abuse, to identify those who may benefit from care plan modification. The assessments are performed on admission and again prior to discharge. And then the second is we utilize positive screens and we address them through intervention strategies. So again, to translate, we look at our patients to see if they have any specific risks. And if they do have a risk, we try to do something about it. That's really all they're asking. They acknowledge the complexity of this undertaking. This is a huge can of worms that health-related social needs and patient vulnerability kind of opens up. And so, as with all of the other domains, CMS does not require the use of a particular screening tool or process. They note that, it's good to have standardized care pathways, meaning that you do have a process where you check every older adult for this, and then you direct them to particular resources. So as soon as you identify someone who has food insecurity, then you give them a referral, or you tell them about your food assistance program. But they don't impose specific requirements for the contents of a comprehensive plan for patients who screen positive. They cite things like, if you do personalized risk assessments, are you connecting with community services? Are you referring to home health? Are you providing meal services or meal vouchers? But again, CMS acknowledges that the particular needs will depend on the patient, and they're very broad about what they're asking of hospitals to attest to. It's looking at the chat for a couple of other questions. It's not the granularity again is not super. It's not super. The point. It's, are you screening for general patient vulnerability? If you do it for all of these things, but not caregiver stress, as your example is, you can still attest positively. The recommendation is that you do screen for caregiver stress, but the point is that you are using some sort of tool that looks at patient vulnerability specifically for older adults. So let's go to the final domain, which is age-friendly care leadership. And this is really just looking if you have someone who's in charge of age-friendly care leadership. The short version of the attestation statements here, and there are two of them, is that you can say that you do have someone or a committee of folks who are identified as the age-friendly champion. CMS does not require this to be a job title or even have a dedicated FTE for this work. Really, it's someone, if your CEO walked into the room and said, who does age-friendly care? Someone would know to raise their hand. Or there's a committee of people who would know to raise their hand. It's just the person who, probably in addition to other work that they do outside of the domains on this measure, they lead the age-friendly work for the hospital. They communicate about this work with hospital leadership. It's probably you who's on this webinar right now. They suggest that the person or group should consist of at least one individual with training in the care of older adults, but they do not specify this needs to be a geriatrician or a level of licensure or practice or a job title or anything. The second item is our hospital compiles quality data related to the age-friendly hospital measure. These data are stratified by variables of interest such as sex, payer source, age, and other factors. The provider determines that are valuable in identifying improvement strategies for our population. So this attestation boils down to asking whether the hospital collects quality data and analyzes it by demographics. CMS very clearly says we do not intend to require new or separate data collection just for this measure. In fact, to limit the data collection burden of this domain, it's recommended to use the measures that you are already collecting as part of a registry for research, or as part of the inpatient quality reporting program. They do cite their own measures in the inpatient quality reporting program, which, if you're attesting to this measure, you are also likely participating with those measures as well. So if you are doing all the other IQR measures, you can say yes to this attestation statement. The intent of this item is not just data collection, but a focus on data-driven improvement utilizing standard validated techniques for quality improvement. The data should be stratified by patient factors that the provider determines important. And it could be things like age, sex, and payer source. It could be things like veteran status or income level, rural versus urban. What's important to your organization and your patients. Can you attest yes if those measures are not currently stratified by age? If you stratify by over 65, 65 and older, and not over 65 and older, yes, you can attest to that. But if you're not stratifying by age at all, then no, you wouldn't be able to attest positively to that. You really do have to look at the differences between the age ranks. So just quickly on the last slide, and I'm hoping we'll have some time for questions. On the last slide, I'll just mention that we do have AHA and Hartford Foundation Age-Friendly Health Systems resources that will help you attest positively to every single one of these domains. In particular, I will call out the December 2nd Action Community Call, which deals with responsible medication management. And again, we will distribute these slides. So for now, I'm going to hand it back to Rahat, but I'm going to go into the chat and work on answering some of these questions as we go to our next portion of our presentation.
Thank you so much, Caitlin. I can tell by the chat that the information was so incredibly helpful. And for those of you who are joining this call outside of our action community and might have a question about, well, what is an action community? It is a 7-month-long virtual learning collaborative that you still have time to join. And we help with implementation of the 4Ms framework within your organization. We have experts that join our virtual calls on a monthly basis. We have peer-to-peer coaching. We have our coach who is available to do one-on-one coaching calls with you. And of course, access to incredible experts like Caitlin and Dr. Mwangi, who you have the pleasure of hearing from today. So I will plug in a link to the action community. And feel free to join. Thank you. Yeah, there's a few questions about how to join, so I will plug in a link. It's a simple registration form and will be open for a little bit of time for like the next couple of weeks. So if you have any inclination that you want to join, please go ahead and fill out that link that I'll be sharing shortly in the chat. And with that, Dr. Mwangi, I will turn it over to you to share a little bit about your journey with the CMS attestation measure.
Perfect. Thank you so much. And thank you, Caitlin, for the deep dive into the CMS domain and what CMS is expecting and the thought processes behind it. So I will try to move as quickly as possible in the interest of time. Next slide. Just introducing who we are. Luminis Health some of you may not know who we are. We are a 2-hospital system in the state of Maryland, located in Prince George's County and Arundel County. And we are very fortunate to have been one of the pioneer age-friendly hospitals in the United States when this movement started with the John A. Hartford Foundation and IHI. Next slide. I wanted to, by way of summary, show you that our journey has taken time. And so if you are new to the age-friendly health system journey, if you are grappling with the CMS attestation, welcome to the club. And I do want to point out 2 things here, that just because it has taken us a long time to get where we are does not mean it will take those who are starting their journey as long, because you have the benefit of standing on the shoulders of giants who have over the last 10 years or so worked on this age-friendly health system journey. And so your start to take off is going to be faster and facilitated by all of the expertise and experience that has been gained over several years. So we have an ACE unit. We did achieve age-friendly recognition in 2019. We are working and continue to work with our emergency department to get the geriatric emergency department accreditation, which we are now at level 3 and working towards level 2. And then we have been very fortunate to join the Age-Friendly Health System Spread Collaborative last year so that we could involve our second hospital in age-friendly care. And we are now in the boat with everybody else working on the CMS attestation, which was announced in the fall of 2024. Next slide. So I wanted to just link how our age-friendly journey has helped in attesting to this CMS measure. So before CMS attestation was announced, we were doing age-friendly care. And this is just an example of a whiteboard in a patient's room at our hospital on the acute care for elderly unit, where you can see the 4Ms in action in the daily care of a patient. By orienting a patient at the top of the slide, you see mentation is taken care of there with the date, the time, where they are located in the unit and in the hospital. And then we talk about what matters as a central feature. And then we highlight important medications, mobility, and any assistive devices patients might be using. And this was our way of addressing 4Ms with patients and families as well as other team members. Next slide. We also, pre-CMS attestation, were documenting the 4Ms in a nursing flow sheet in Epic. So those of you who use Epic, we have a care plan for adults 65 and older, where all of the 4Ms are documented by the nurses as they go through their work. So again, our 4Ms journey was preparing us for the CMS attestation, even though we didn't know that it was coming. Next slide. When the CMS attestation was announced in 2024, we created a checklist which will be shared with you in the chat group, and it is available on the IHI website as well. And this was our way of breaking down all of what CMS was asking of us into actionable items. And so taking each of the domains, taking the specifications, the elements that are specified in the domains, and asking ourselves, what are we already doing because we were already on an age-friendly journey? And then what is something we are totally not doing that we now need to pay attention to? And what are some things that are in the works? And so this checklist is available for everybody's use as an example of a tool that you can use to sort of walk through your hospital, walk through your units to say, what are we doing? What are we not doing? What are the works in progress so that we can work towards attesting, making the CMS attestation. So on the next slide, we wanted to share an example of our checklist as it is today. So this is a real example of our domain 4, which we've been grappling with. And it shows you that under social vulnerability, we have some yeses in the first column there where you see the X's, and we have some pending, some work in progress. And so this is just to show you that this attestation checklist is meant to be a living document, a working document that you use to go through things with your age-friendly team in your hospital and to document your progress as you work towards making the attestation. Next slide. So in domain 1, in eliciting patient healthcare goals, I wanted to spend a little bit of time here just because this is the domain that we have very many questions about. And it's not just nationally in the US, even in our international work with IHI, what matters seem to be a very interesting M to grapple with patients and healthcare providers. So this is an example of our history and physical, our admission note. And so when a hospitalist is doing an admission, at the bottom of the note, we have, as you can see, most advanced directive and code status. And so when you click on review of the most, you now see that you have the capability to say, is there a most available? Or isn't there one? And for those who are not familiar, this is the Maryland Orders for Life-Sustaining Treatment. I know that these forms are available in different states under different names, but essentially, is there a document that tells us the patient wishes if things change and they are critically ill especially. And then if you click on the advanced directive review, what you then see is, do we have a copy of the advanced directive or not? And if we do have one, what is the date of that advanced directive, so that you can document that you're reviewing this document in real time. And finally, when you look at the code status, you will see that as well. You will find, if you can click next, yeah, you will see that, well, when you review the most, you have an opportunity to document with whom you reviewed the most, and you have a drop-down menu, and as well as the code status being pulled in from your admission orders. So this is an example of how you can be doing your regular day-to-day work and establishing processes within your work that can help you attest to domain 1 successfully. Next slide. I put this up again for the EPIC users. I'm sorry that I am not familiar with Cerner or other EMRs, but I know that other people who are working on these EMRs can also help with what that looks like in using them. So this is another patient from our playground environment where we are demonstrating on this slide how you can document active healthcare agents. If you can look at the information highlighted in the red box, you can see the healthcare agents can be named there, and advanced care planning notes can be documented. Next. And then I just wanted to demonstrate that in EPIC, you can also actually go into the Advanced Care Planning tab, and you can actually document individually what matters to the patient and the family, what their daily goals are, what their concerns are. And on the next click, you see here that all of what you document in this box shows up under what matters most in the patient summary tab. And so you can see now that the thing that matters most to the patient shows up right up front on the patient summary page, and that can help you attest to domain 1 successfully. Next slide. In domain 2, we talk about responsible medication management, and Catilin has already given us the details. I wanted to just highlight here in the black box that when you order something like Haldol, I don't know how clearly this shows up for you, but this is one of the potentially inappropriate medications. Then best practice advisories show up to tell you about BIAS criteria. And then on the right-hand side is an example of how you can review prior to admission medication lists. And in that review, you can identify potentially inappropriate medications and flag them for discussion with patients or their primary care physicians after discharge. Next slide. In domain 3 is a complicated domain. It has at least 4 subsections, and in each of those subsections, they require quite a bit of detail. So in 3A and B, CMS wants us to address mentation, mobility, and malnutrition. And on my next slide, I show you how in our hospital, even prior to CMS, we had already chosen the brief CAM assessment as the delirium screening tool of choice for our inpatient setting. And therefore, this is an example of the nursing flow sheet where nurses can go through the brief confusion assessment method elements and document them very clearly in the flow sheet. And on the next slide, they also have not just the ability to screen, but also to act, which is something that the domain stresses in 3B, that positive screens result in management plans to minimize delirium risks, encouraging mobility, and implementing nutrition plans as appropriate. So this is an example of not just screening, but screening followed by actions that can help the patient. Next slide. From the hospitalist standpoint, when the nurse has completed their screening, you can see there in the middle of the screen, when this is an actual patient list of my census a few weeks ago. And you can see here that when the brief confusion assessment test is positive, it will show up as in red that the screening is completed and the patient is positive. For those the screening is completed and they're negative, this does not show up. And so now I know that of all my patients, there are 2 that have delirium. And therefore, the screening shows up on my list as a physician, and it helps me to plan what interventions I have for them. So this granular detail, as Catilin has told us, is not necessarily required at this time, but these are just illustrations of how your work processes and policies and procedures can help meet the attestation. But beyond meeting the attestation, they can help you actually provide quality age-friendly care to your hospitalized older adult. Next slide. And here I show you an example of a delirium prevention panel. Again, most of these interventions were present in our hospital pre-CMS attestation, and therefore we are now using what we came up with during our age-friendly journey to help us meet the attestation. Please move to the next slide. I know we are short of time. I will now go to domain. So in this is another example of a de-escalation order set that we use in the emergency department, but also in the inpatient setting for patients who are screening positive for delirium. Next slide. So domain 3 also requires us to look at physical function and mobility. We're using the Johns Hopkins highest level of mobility and trying to focus our attention not just on fall prevention, but on assisting and encouraging mobility. Falls have been a focus for CMS and for the hospitals for a very long time, and with good reason. But we have found that when you focus on falls, you find that sometimes we end up limiting patient mobility because of that. And so we've turned it around now, and instead of being anxious and worried about falls, rather taking a positive twist on it and say, how can we assist and encourage safe mobility in the hospital? We've come up with there are very evidence-based limited indications for bed rest, which are very specific, and those are the only ones that we are now allowing ourselves to use for bed rest. Otherwise, all patients should have activity plans. We want to document the first time to mobility, and we want to document the percentage of patients who meet their highest level of mobility, and again, and also the percentage of patients who are being mobilized daily. So taking the opportunity to attest to also improve our mobility across our hospital. Next slide. We then also have to address malnutrition. Again, in EPIC, once the data is in place, you can always see patients' BMI. You can actually pull into your notes as clinicians all of the weight a patient has had. And this triggers a nutritionist assessment and dietary recommendations. So again, these are granular details, just showing how the day-to-day work and clinical assessment that you're doing can help to attest to that measure in domain 3. And then moving on, the other sections on falls, decubitus, ulcers, and 30-day readmissions. I think Catilin addressed this. So we were already reporting these things, and CMS is not requiring us to reinvent the wheel, but to continue to use current tools to report those 3 measures. Next. In domain 4, which has been, domain 3D, I'm ahead of myself. So the emergency department, there was a lot of questions about the emergency department. The CMS attestation measure does specifically reference the emergency department in domain 3D. And in answer to that, we have a comprehensive geriatric evaluation in our emergency department that was actually designed to target the length of stay of our patients in the ED because of how many EDAs we were having. And so in the process of addressing a current problem in the emergency department, we also now were able to address this section of the CMS attestation. So we're targeting our older adults coming from the community and skilled facilities, fast tracking them to a geriatric evaluation using the 4 M's. And our goal is to do not just reducing the length of stay, but also facilitating early and safe discharges and supporting them in the first 30 days after discharge from the ED. And we're also seeing benefit when these patients are admitted. So again, an intervention that was answering a question regarding EDAs, patients, older adults boarding in the ED, has now turned around to help us also meet that attestation. Next
Dr.
slide.
Mwangi, this is fantastic, and we are right at time. And
Yes.
what better place to end than the potential outcomes that other organizations can expect to see when they begin their age-friendly journeys? I wanted to highlight quickly the message that Caitlin had shared, saying that this measure is likely to continue in the future. So, all of that to say, I did see a few registrations come through during this webinar. I do want to apologize that my chats were not working for the entire group. So a few of the delayed chats are being sent, and one of those chats is including a link to the registration page, which again, I did see a few individuals from this call submit the registration live during this webinar. If you found this webinar helpful and knowing that this is a measure that is going to continue in the future, as Caitlin had suggested, please feel free to go ahead and get that link, register so that you can continue to get other helpful information, hear from these amazing experts who will help you with your age-friendly journey. We're here to make it easier. Again, as Caitlin had mentioned at the very beginning of this call, it is very, very likely that a lot of you are doing the majority of this work. We are here to help you fit that into the framework and fit that so that it meets the needs and it meets the attestation requirements. And of course, the very bottom line is so that it improves care for all older adults within your organization. So if you found this webinar helpful, please go ahead and register. I know there's still a few questions that are being asked in the chat. Continue to ask those questions. We will respond to the questions via email after we send when we send all the materials. And I did have a request to send the chat as well, which we will be sure to do that. So thank you again for your time, and look forward to seeing you all in different age-friendly opportunities and specifically the age-friendly action community coming up. Take care, everyone.